We need to now to move to our final speaker in the oral presentations. I'm happy to welcome Emilie Lauressergues. Emilie holds a PhD in molecular and cellular biology. She has a background in research and development of models for screening and characterization of new molecules for various therapeutic areas. She joined the Pierre Fabre Foundation in 2015 as scientific officer and is responsible for managing research studies, instructing health projects, and coordinating expert working groups. Her presentation is entitled Acceptabilité, performance diagnostique et faisabilité du dépistage néonatal de la drépanocytose à l'aide de deux tests diagnostiques rapides, SICKLESCAN et HEMOTYPEC SC au Mali. Merci, Emilie.
I would like to thank MSF for having selected the study for an oral presentation. This thanks to a collaboration between the Bamako Sickle Cell Foundation in Mali, the INSEM, and the Pierre Fabre Foundation. This study aims at assessing the diagnostic performance, but also the feasibility and acceptability of neonatal sickle cell screening of sickle cell disease using two tests, two RTDs, the SICKLESCAN and HEMOTYPEC in Mali. This presentation has 5 parts: introduction, objectives, methods, findings, and conclusion. So, sickle cell disease, a genetic disease that is due to a hemoglobin anomaly, and it has an autosomal recessive transmission. There are several variants of abnormal hemoglobin. The most well-known one is the SAS1, and this is going to have major consequences, clinical consequences in individuals, especially vaso-occlusive crises that are extremely painful because of the obstruction of small vessels, hemolysis, and severe anemia, the necrosis of tissues, and increased risk of a stroke. And the major crisis is characterized by severe forms in SS and SC individuals. This is the genetic disease that is the most widespread worldwide, 300,000 births per year, and 3/4 of them in sub-Saharan Africa. Mortality is estimated to be between 50 and 90% in children under the age of 5 if there is no care provided to them. Fortunately, early screening plus appropriate preventive measures allow to reduce significantly up to 70% the mortality and morbidity. The diagnostic of this disease is done in a lab with all the constraints that we all know: cost constraints, timelines, competencies, human competencies and skills. This is a reason why those rapid diagnostics tests have really changed things around in the area of screening. We are talking about a limited resource setting in Mali, and we need to assess those strategies, those RDT strategies to public health officials. So we wanted to assess the intrinsic and extrinsic performance of those two RTDs for routine neonatal screening, and we compared it with the standard technique, which is HPLC, in 3 maternity wards in Mali, 2 in Bamako. And secondary objectives, assessing the acceptability of neonatal screening by families, and also assessing the feasibility and acceptability of those RTDs by healthcare professionals. So we're doing about a 4-month period in 2021. Once the mother had provided her informed consent, all live-born infants were assessed. We collected the blood cord, and based on those samples, we carried out the 2 RTDs and also the HPLC test. So out of over 4,000 women, 84.6% accepted to take part in the study. Only 1.4% said no, and the difference is 15% between the locations. It actually corresponds to either emergency situations, obstetrical emergencies, or because women didn't have enough time to go further. So 640 children were included in the study. So we consider that based on the data, we have a very good acceptability rate. The chosen scenario has allowed us to study the capacity of both tests to discriminate between the various types of sickle cell diseases. And this study has also allowed us, because we had a good sample, to highlight new prevalence data at both 1.64% of SDM, which is quite important. Now, regarding the diagnostic performance, I would like to draw your attention to the predictive value, negative predictive value of the test, which is of the sickle scan, which is almost perfect, and hemotype also, which really allows us to exclude all individuals who are not impacted by the disease. And now we assume, we see that the positive predictive value is sufficient. Those tests have a good reliance, and it is relevant to use both tests in order to carry out a screening strategy. The acceptability by healthcare professionals was assessed also. 69 people were involved, and this was a self-administered questionnaire. I cannot tell you that 94% would accept to carry out a routine screening if it were invoiced. So those are very good findings. So to conclude, this study was carried out according to international standards on a consequent number of people, and really it was performed on cord blood, which is quite original. So those RTDs are very reliable in order to screen the infants. And this could allow us to implement a screening program at both in a limited resource context. A very good acceptability by the population and also by healthcare professionals. And we also now have updated prevalence data regarding the disease at birth in Mali. So this is a good tool for those resource poor contexts. And I would like to thank all our partners, including Professor Guindo from DCRLD, Dr. Valériane Leroy, and Valentina Pico, and everyone has taken part in this study also. I would like to thank you for your attention. Thank you. Thank you so much, Emilie. So I would like to know, so you said 85% have accepted to do the test. So I'm interested, what about the 15% or so no? Why did they say no? Well, 1.4% refusals. No, the 15% difference between those who signed the consent and the others, actually due to obstetrical emergencies, no C-sections, no real emergency situations, or other cases where midwives did have the time to include the mother in the study, which really shows that the relapse rate is actually the refusal rate is very low, 1.4%. So good acceptance. Okay. Okay, thank you for this presentation. Could you also explain how the tests were carried out? And following the diagnosis, what kind of follow-up or care is being made available to those children? Thank you. Well, thank you for asking the question. I mean, the blood cord blood is collected at birth, obviously, and the rapid tests are done immediately at birth, in the delivery room, using a small drop of blood for each test. And the technique, the benchmark technique is done afterwards at the research center a few days afterwards. Once the children have been diagnosed as having a major sickle cell disease syndrome, and they receive antibiotics until the age of 5 with penicillin. Vaccination also is essential. And they also receive a folic acid because of the risk of anemia. I think we have enough time for one last question. So what is the tool used in order to assess the acceptability by healthcare professionals? Did you use the NICA scale? No, we didn't use that scale. It was just a self-administered questionnaire with questions regarding the ease of use, for example, and the way they perceive things, but we didn't have the scale that you just mentioned.
Merci beaucoup.
Okay, then, thank you so much, Emilie. Thank you.
So if you have questions for Emilie, any other questions coming through, please feel free to reach out to her during conversations over coffee or take up a private chat.